ഇത് കൊടുത്തിട്ടില്ല, മോണിറ്ററിങ് കൊടുത്തിട്ടില്ലല്ലോ.
Ecosystem within our university and beyond. We are just moments away from the commencement of the program. We request everyone to be seated in the hall as we begin the formal function at 10 a.m. We request everyone to maintain decorum within the hall and keep your mobile phones in silent mode. Thank you and welcome once again to KUHS Annual Research Day 2025.
Sir, good morning.
വീണ്ടും സന്തോഷം
ആ ആ പറഞ്ഞിട്ടില്ല, അറിയില്ല, തുടങ്ങി പറഞ്ഞിട്ടില്ല. ആ ആ ശരി. ആ പതിട്ട് ശരി. ശരി. ഏത് പവറാ? പവറിൽ.
Morning all. We request everyone to please stand for the university anthem. Jeevan, 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 Amulyamana Devasthitvam, Jnanamana Devadharam, Anandamapam, Nidhudaramana Divyasam, Divyam, Kandanataram Kalam, സംഗീതം പഞ്ചചേതന സുന്ദര കനിഞ്ഞു നൽകിയ സമ്മാനം ഓരോ പ്രാണതലങ്ങളിൽ എഴുതിയ നിഗൂഢമന്ത്രരഹസ്യങ്ങൾ തിരിച്ചറിഞ്ഞൊരു ശാസ്ത്രമിതെന്നും തലോടി മാറ്റും വേദനകൾ നിതാന്ത ജാഗ്രതയോടരികത്താൽ കാവൽ നിൽക്കുന്നവർ ഞങ്ങൾ കൂടെ നിൽക്കുന്നവർ ഞങ്ങൾ സർവേ ഭവന്തു സുഖിനാ സർവേ ഭവന്തു സുഖിനാ സർവേ ഭവന്തു സുഖിനാ.
Thank you. Let us now invite Professor Dr. Shaji K.S., Dean Research, Kerala University of Health Sciences, to deliver the welcome address.
Good morning, everyone. The Honorable Vice Chancellor, Professor Mohan Kundumal, the Pro Vice Chancellor, Professor C.P. Vijayan, Registrar, Dr. Gopalkumar, statutory officers, faculty members, guests, my dear students. Let us begin with congratulating the trainees and mentors who managed to successfully complete a research project and is getting awarded the UG Research Appreciation Award today. Your presence makes this day very special. for you and all of us here. We also have two eminent researchers who have made significant contributions to health sciences in general and epidemiology in particular. So, on behalf of all of us, I take this opportunity to welcome Professor Vikram Patel, who is Paul Farmer Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School. Welcome, Vikram. We are also delighted to welcome Professor Pankaj Bharadwaj, Professor of Community and Family Medicine and who heads the School of Public Health at AIIMS, Jodhpur. Thank you, sir. Let me also make one point here. Reimagining the undergraduate health science training is our vision. We have started making a difference by initiating the UG Research Appreciation Award last year. We are reviewing the progress and initiating a year-long stakeholder engagement program from today. So, on behalf of all of us in KUHS, we welcome you who are present here in person and who are online watching the YouTube video. This is a collective effort, and we believe that good health depends on good research. And we want to do research which will empower us and guide our practice. So welcome to everyone here. Thank you very much for coming.
We are very much honored to have with us Professor Dr. Mohanan Pudumal, the Honorable Vice Chancellor, Kerala University of Health Sciences, in this function. We request Professor Dr. Mohanan Pudumal to deliver the inaugural address.
Good morning. എല്ലാവർക്കും നമസ്കാരം. Most respected Professor Vikram Patel, who have come all the way from Harvard, and Professor Pankaj Bharadwaj, who has come from AIIMS, Jodhpur, and my colleagues in the university, eminent teachers and students, researchers. For us, this is a very important day, research day of the university, and probably this is the first research day we are organizing, and this is going to be the first and this many years. Kerala University of Health Sciences is almost 15-year-old, and in this 15 years we have established as a good teaching university with a great reputation, and students from this university is recognized all over the globe. But in the research scene, I have to admit that we have not created a great name. And that is the endeavor we are doing. Now, how do you start? You start from the youngest, catch them young. Probably, I don't think any other university, at least in the health science, has done what we have done. We have declared a scholarship of 10,000 rupees for undergraduate students, and that also 1,000 students. And last year, we had 300 applications because the information may not have gone wide. 185 students have completed the research, and all of them have submitted whatever they have done. It is with us. And today morning, all the 185 students have got 10,000 rupees. We have today morning, our finance officer has transferred that amount. They can verify in the mobile phones. And this year, we have got 900 applications. So from 300, it has become 900. Next year, I'm very sure it will become 9,000. So this is the way. And many of the research projects are extremely good. And why we are focusing on our undergraduates? They are the future. They are between 18 to 23 years. Health science, almost 1 lakh students. We have 1 lakh, more than 1 lakh. What transformation they can do? If each one of them have got a research mind, we are not expecting all of them to become Einsteins. But in the health science, each and every problem they are facing, they should know how to ask questions. They should verify what has been taught. They should not accept what has been said. They can say there may be an alternate way also. So this is what the research mind has become. And in that process, a lot of publications will come, a lot of discoveries will come. And these students are very, very important in the sense, after 20, 25 years, they become 40, 45, and India will become 100 years old. 2047, that is the year we are targeting. 2040. So during that period, these are the youngsters who are going to lead not only the state, not only the country, but the globe. And when we become the global leaders, we have to train. And this is the one single purpose with which we have started this. And I congratulate each and every one of the students for joining this university's march, especially the teachers, the faculty. You have done a great job. Thank you very much. This is going to be a big long. Thank you. Thank you, sir.
Thank you, sir, for your thought-provoking words.
We would like to invite Professor Dr. C.P. Vijayan, the Pro Vice Chancellor, for the felicitation.
Good morning, Honorable Vice Chancellor, my colleagues in the university, Dr. Vikram Patel, Professor Pankaj Bharadwaj, eminent teachers, researchers, and my dear friends. Research methodology is a paper for examinations in most of the undergraduate programs conducted by Kerala University of Sciences. So they learn, undergraduate students, they learn research methodology theory part. But where is the practical training? This undergraduate research program and the award, it is meant for the practical training. As mentioned by Honorable Vice Chancellor, tomorrow, all of them, not only those who got awards, but students who participated in this program, they will be able to conduct research and become leaders in research activities. Our Dean Research is actively behind this program, and our Vice Chancellor is supporting it wholeheartedly. So success is assured. I wish all success for this program. Thank you.
Thank you so much, sir.
We now move on to a special part of our program, the facilitating of our esteemed awardees. First, we are honoring PhD holders of the university. We request all the PhD holders of KUHS to please come forward when their names are called. We request Honorable Vice Chancellor to distribute the mementos.
Dr. Jayanti R, PhD, from Faculty of Nursing. She is one of the first PhD holders of the KUHS.
Dr. Babida E, PhD, from the Faculty of Nursing. She is one of the first PhD holders of KUHS.
Dr. Gino Joseph, PhD from Faculty of Pharmaceutical Sciences.
Dr. K. Soya, PhD from the Faculty of Nursing.
Dr. Rajani ER, PhD from Faculty of Dental Sciences.
Dr. Anupama Krishnan, PhD from the Faculty of Ayurveda.
Next, we are honoring 3 PhD candidates who have successfully completed open defense and are all set to receive the PhD degree in the next convocation.
Elizabeth Workey under the Faculty of Nursing.
Ashwati M under the Faculty of Ayurveda.
Namita P, first full-time PhD holder of KUHS Research Center under the Faculty of Nursing.
Next is distribution of cash awards and certificates to the winners of Best Thesis on Breastfeeding 2018 to 2023, conducted as part of observance of World Breastfeeding Week. We request Honorable Vice Chancellor to distribute the cash award and certificates.
First prize, Ms. Deepthi SL. She will be receiving a check amounting to Rs 5,000. Second prize, Ms. Rudy MJ and Ms. Gayatri Krishnan. Each will be sharing a check amounting to Rs 2,500.
Next is distribution of much awaited KUHS Research Appreciation Award 2024. We request the principals of the respective institutions to please come forward and receive the certificates on behalf of their students.
From the Faculty of Dental Sciences, Indira Gandhi Institute of Dental Sciences, Kodamangalam, which won 15 awards, which is also the highest among all faculty.
From Faculty of Medicine, it is Jubilee Mission Medical College and Research Institute Thrissur, which topped the list with 12 hours.
From the Faculty of Pharmaceutical Sciences, Caritas College of Pharmacy, Tellagam, Kottayam with 10 awards.
From the Faculty of Nursing, it's Bishop Bensical College of Nursing, Kollam, which topped with 5 hours. From the Faculty of Nursing, it's Bishop Bensical College of Nursing, Kollam, which topped with 5 awards.
From the Faculty of Allied Health Science, we invite Halia School of Optometry and Research Center, Palakkad, which secured 9 awards.
Faculty of Ayurveda, Vaidyaratnam Ayurveda College, Ollu, Thrissur has secured 2 awards.
We request Professor Dr. C.B. Vijayan sir to give certificates to the remaining colleges from Faculty of Medicine. Dr. Somerville Memorial CSI Medical College, Karakoram with 10 awards. Pushpagiri Institute of Medical Sciences and Research Center, Tiruvalla with 10 awards.
Pushpagiri Institute of Medical Sciences and Research Center. KMCT Medical College, Kozhikode.
Government Medical College, Kollam with 6 awards. Government Medical College, Kollam with 6 awards. Amala Institute of Medical Sciences, Thrissur with 5 awards. Amala Institute of Medical Sciences, Thrissur with 5 awards. MES Medical College, Malappuram with 5 awards. MES Medical College, Malappuram with 5 awards. Malabar Medical College, Hospital and Research Center, Kozhikode with 5 awards. Malabar Medical College, Hospital and Research Center, Kozhikode with 5 awards. Government Medical College, Palakkad with 5 awards. Government Medical College, Palakkad with 5 awards. Malagara Orthodox Syrian Church Medical College, Kolanjeri with 4 awards. MOSC Medical College, Kolanjeri with 4 awards. Government TD Medical College, Alappuzha with 2 awards. Government TD Medical College, Alappuzha. Government Medical College, Ernakulam with 2 awards. Government Medical College, Ernakulam with 2 awards. Government Medical College, Thrissur with 1 award. Government Medical College, Thrissur, with 1 hour. Government Medical College, Kozhikode, with 1 hour. Government Medical College, Kozhikode, with 1 hour. Karuna Medical College, Palakkad, with 1 hour. Karuna Medical College, Palakkad, with 1 hour.
We request Professor Gopakumar S, Registrar, to give certificates to colleges from Faculty of Dental Sciences, Faculty of Nursing, Faculty of Ayurveda, and Faculty of Pharmaceutical Sciences. First, PMS College of Dental Sciences and Research, Thiruvananthapuram. They have won 11 awards. PMS College of Dental Sciences and Research, Thiruvananthapuram. Mar Basilius Dental College, Ernakulam. Mar Basilius Dental College, Ernakulam. They have won 10 awards. Pushpagiri College of Dental Sciences, Tiruvalla. Pushpagiri College of Dental Sciences, Tiruvalla. They have won 5 awards. Anur Dental College, Muvatupura. Anur Dental College, Muvatupura. They have won 3 awards. Educare Institute of Dental Sciences, Malappuram. Educare Institute of Dental Sciences, Malappuram. They have won 2 awards. From Faculty of Nursing, Amala College of Nursing, Thrissur. Amala College of Nursing, Thrissur. They have won 4 awards. St. James College of Nursing, Chalakudi. St. James College of Nursing, Chalakudi. They have won 3 awards. NIMS College of Nursing, Neyyattingara. NIMS College of Nursing, Neyyattingara. They have won 2 awards. PRS College of Nursing, Thiruvananthapuram. PRS College of Nursing, Thiruvananthapuram. PRS College of Nursing, Thiruvananthapuram. From Faculty of Ayurveda, Government Ayurveda College, Thiruvananthapuram. We have PRS College of Nursing, Thiruvananthapuram. They have won 1 award. Next, from Faculty of Ayurveda, Government Ayurveda College, Thiruvananthapuram. Government Ayurveda College, Thiruvananthapuram. They have won 1 award.
From Faculty of Pharmaceutical Sciences, Grace College of Pharmacy, Palakkad, who has won 9 awards. Grace College of Pharmacy, Palakkad. Chancellor College of Pharmaceutical Studies, Palakkad, with 7 awards. Chancellor College of Pharmaceutical Studies, Palakkad, with 7 awards. Eduthachan College of Pharmaceutical Sciences, Thiruvananthapuram, with 4 awards. Eduthachan College of Pharmaceutical Sciences, Thiruvananthapuram, with 4 awards. Nirmala College of Health Sciences, Thrissur, with 2 awards. Nirmala College of Health Sciences, Thrissur, with 2 awards. Ahalya School of Pharmacy, Palakkad, with 2 awards. Ahalya School of Pharmacy, Palakkad, with 2 awards. KTN College of Pharmacy, Palakkad, with 1 award. KTN College of Pharmacy, Palakkad, with 1 award. Mark Diascoros College of Pharmacy, Thiruvananthapuram, with 1 award. Mark Diascoros College of Pharmacy, Thiruvananthapuram, with 1 award. Thank you all. With this, we complete the award ceremony. We now move on to the next session. We now invite Professor Dr. Gogomar S., Registrar, Kerala University of Health Sciences, to deliver the vote of thanks.
Good morning, respected Vice Chancellor, Professor Dr. Mohan Pundamal sir, other invited dignitaries on the dais, dear friends. We have so many activities to be followed, so I am not taking much time. Every time when we talk about research is always on the paper, not in the action. So this time, Kerala University of Health Science decided to have very serious support, to give very serious support to the emerging buds in research. That is why we selected the UG students. As Honorable Vice Chancellor sir told, next year onwards, we expect that more people will be coming for this competition, not a competition, but really a competition for the better future of the medical science. So I am straight away entering to my responsibility. We express our sincere gratitude to Honorable Vice Chancellor of the Kerala University of Health Science, Professor Dr. Mohan Pundamal sir, who inaugurated this function. Thank you, sir. Now I am expressing our sincere gratitude to our Pro Vice Chancellor, Dr. C.P. Vijayan sir. Thank you, sir. And this wonderful event is possible only with the presence of 2 great eminent scholars. And yesterday itself, they were here. And I express our sincere gratitude to Professor Dr. Vikram Patel, sir, who will be delivering the presentation. Thank you so much, sir. And today we are having another keynote address, which will be delivered by Professor Dr. Pankaj Bharadwaj. I express our sincere gratitude to sir. Thank you, sir. And I express our sincere gratitude to all the invited guests, all the teachers, all the principals, all the award-winning students, and all the employees and officers of KUHS, And today let us dedicate it to the entire day. We will be dedicating to the research related activities. I would like to quote one quote from the Charaka Samhita, which is the oldest textbook of medicine, which is telling about the research centuries back. Vidya Vitarka Vijnanam Smriti Tatparada Kriya Yaside Shadgunas Tasya Na Sadhyam Adivartade. The meaning is very simple. Continuous activities in discussion, debate, scientific interaction will be leading to fruitful results. And I believe that our young generation will be coming with the wonderful results in the future. Wishing them all the best. And once again, thanking you. Thank you all.
Thank you so much, sir. Congratulations to all the winners. We will now have a short tea break. The tea break will be for 15 minutes. Please enjoy your refreshments and come back soon. Gentle reminder, please come back by 11 a.m.
ഞാൻ ഇവിടെ ആൾക്കാരാണ്
UG Research Appreciation Awards. So on behalf of KUHS, I would request the Pro Vice Chancellor to Can I also request you to, we will soon, it will be available on the website, the issue of newsletter. So can you give it to, can you release it by giving it to sir? That will come on the website now. This is a monthly newsletter. The editorial speaks about the importance of community-based care. Thank you very much.
I request the chairpersons of the session, Professor Dr. C.P. Vijayan, Honorable Pro Vice Chancellor, and Professor Dr. Shaji K.S., Dean Research, to take their seats on the stage. I request Dr. Shaji K.S. to introduce the orator to the audience.
Yes, now we will have Kerala University of Health Sciences oration by Professor Vikram Patel. I request Professor K.S. Shaji to introduce the orator.
Thank you, Vikram, for being here. Vikram Patel is the Paul Farmer Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School. He holds an honorary professorship in Harvard Chan School of Public Health, London School of Hygiene and Tropical Medicine. His work has focused on burden of mental illness and use of community resources for prevention and treatment of mental health issues. He has a number of publications, more than 400 peer-reviewed articles, many books, chapters, and he is ranked among the top 0.05% of scientists, according to Clarivate. He co-leads the Lancet Commission on Global Mental Health and Sustainable Development. And for the undergraduate trainees, he is one person who took up research as a career from very early days after his MBBS. So I'll not, you can look his CV and details on the net. So over to you, Vikram. Thank you very much.
Thank you, Dr. Shaji, and thank you to the Vice Chancellor and the leadership of KUHS for the honor of delivering the oration today. It's a real pleasure to be here with the deans and the leaders of so many of the medical, nursing, pharmacy, and allied science colleges in Canada, and to see how much effort is being placed to integrate a culture of inquiry, a culture of reflection, a culture of publication within the undergraduate curricula. Certainly, my own memory of being a medical student in Mumbai back in the 1980s, we were focused almost entirely on learning clinical skills, which of course is why most of us join one of these colleges. But I do believe that we had a missed opportunity to also offer undergraduate students the opportunity for those who had an aptitude to learn research skills. So I wanted to really spend this opportunity to share with you how powerful research that is done in our country and indeed in our region of South Asia can not only transform healthcare policy and practice within the region, but also in fact transform the way the world views the innovations that come from our region. And we often think of innovations in a highly technological sense. When you hear the word innovation, the first thing that comes to your mind is, something that's happening in a laboratory or something that's happening in a company that is developing new technologies. But I'm going to suggest to you provocatively that the single most important innovation that has come from South Asia and that is transforming global health is actually not a sophisticated innovation that comes from the private sector or from a laboratory, but in fact is an innovation that is entirely related to a grassroots approach towards the addressing of health problems. So that's what I'm going to focus on today. I want to, as many of you know, I am a psychiatrist, and while most of my work has been devoted to the area of mental health, I've also been very deeply involved in other areas of health in India, which I'll touch upon later. But most of my talk is going to refer to the work on mental health in South Asia, in order to just give you a sense of why I believe that these grassroots actions are actually the most innovative, transformative of all health interventions that have emerged from India. So let me start with this, the National Mental Health Survey. This was and is the largest epidemiological study of the prevalence and the response to mental health conditions in adults ever undertaken in India. The study was coordinated by NIMHANS, but in fact was commissioned by the Ministry of Health and Family Welfare. I served on the technical advisory group of this first survey, and I know now there is a second wave that is being currently planned. So when the report was published a few years ago, obviously being an epidemiological study, the most important question that we might be interested to ask is, what is the prevalence of mental health conditions, diagnosable mental health conditions, in this random population sample of over 30,000 adults drawn from across India's different states? It turns out that the number is approximately 100 million. Let's pause and reflect on this number for a little moment. 100 million adults, according to the National Mental Health Survey of India, are currently experiencing. This is not a lifetime prevalence, it's a current prevalence of one or another form of a mental health condition, which of course also includes substance use conditions. But I want to draw on two other facts that the National Mental Health Survey actually illustrates, which to me are actually even more important than the absolute number of people who are living with a mental health condition. The first important fact is that these conditions are not equitably distributed in the population. What does this mean? As you can see on this slide, I'm showing you the prevalence of one of the most common mental health conditions, depression, according to how wealthy or poor you might be in that sample. And what's very clear from this slide is that the richer you are, the lower is your prevalence of depression. And what this demonstrates is something that is true of most health conditions, is that social disadvantage, in this case in the form of poverty, is strongly associated with poor health outcomes. The point I'm making here is that we haven't fully acknowledged that in the mental health space, this is also true. We freely acknowledge, for example, that maternal mortality or tuberculosis is more common amongst the poor. Here is evidence from the National Mental Health Survey that that inequity is also true for the most common mental health conditions. And if I had to show you psychosis, for example, you will also see a very similar pattern. So that's the first additional number that we have to consider, or metric that we have to consider from the National Mental Health Survey. And the second one is, what is the proportion of people with a mental disorder who are currently or have recently received care from the healthcare system? This does not mean any kind of care, because of course many of us will go to our neighbors, we will go to our religious places. This is specifically about the allopathic care system. And this is a staggering set of numbers. Essentially, in a nutshell, between 75 to 85% of people in the national sample have received no care at all in the previous 12 months. None. Which means that we flip it the other way, that only 10 to 15% of people actually receive care. And we're not even talking about the quality of care. We're only talking about having access to a healthcare facility. And I think, as all of you know, simply going to a facility doesn't mean that you're going to get the care you need. This is, in my mind, probably the largest unmet need for healthcare for any health condition in this country. And for me, this is the single most important metric that we as people who are concerned with public health and community medicine in India must be focused on. Now, immediate question that comes to our minds, if we had to ask, for example, mental health professionals, or we had to ask policymakers, why is there such a massive unmet need for care? The standard response is going to be because we don't have enough mental health professionals. And that is absolutely true. In this slide, you can see the most populous countries of the world, and you will see them labeled there. And you'll see the population of those countries on the x-axis, and on the y-axis, you will see one cadre of mental health professionals, that is psychiatrists. And I'm going to compare two countries here, two countries that I live and work in and I'm familiar with, the United States and India, in those red circles. And what's very evident here is that when you adjust per capita, that India has a minuscule number of psychiatrists compared to the United States. So the question to ask us is, does this massive amount of psychiatrists actually create a different outcome on the population when it comes to mental health metrics in the US? Because I guess if you really took the position that we need more mental health professionals as the only strategy to address the burden of mental health problems in the population, then the United States should be doing really, really well. In fact, not only does the United States have a very large number of mental health professionals, and by the way, that's only psychiatrists. If I had psychologists, the number is astronomical. I mean, there is, India would not even be on that chart if I had to include psychologists. But it's not just human resources that the United States does very well in. It's also the amount of money that the US is spending on mental health care. Contrary to what most people in the United States think, that we in the US don't spend enough on mental health. In fact, as this chart shows, the US spends more on mental health care than on any other group of health conditions, including, in fact, extremely expensive health conditions, such as, for example, cancer. So, the US spends a lot of money. A lot of it is spent on mental health professionals working in hospitals. What has been the impact of this vast amount of money and this huge mental health specialist resource? Well, certainly at the population level, none at all. On this slide, you can see that the prevalence of the most common mental health condition, that is depression, over the last 20-odd years has not only not changed, but in fact, in the youngest Americans, it's gone up by nearly 30% during this period. Typically, if you had to show you a slide of, say, cardiovascular disease mortality, you would find a steep decline over this period. Even some of the untreatable conditions, like Alzheimer's disease, are also showing a decline. But when it comes to mental health conditions, there is not only no decline, but in fact, there is a worsening of trends. The most hard metric, of course, in health, in terms of population burden, is mortality. The US is witnessing currently the worst increase in mortality associated with behavioral health conditions in modern history. As you can see here, these are called the deaths of despair, a term that was coined by the economist Angus Deaton, who received the Nobel Prize in economics for this exact work, where he and his collaborators demonstrated that since the year 2000, the numbers of people dying of suicide and substance use-related mortality, which they clump together as the deaths of despair, has risen astronomically. And in fact, these conditions today are the #1 cause of death in Americans between the ages of 14 and 15. In other words, if you're a young or middle-aged American, the chances of mortality are the highest because of a mental health or substance use condition. In spite of the huge number of beds compared to India for sure, and all the services in the United States, tonight, more people with a psychotic or a substance use condition will sleep in a prison than they will in any form of healing or in their own homes. In fact, the situation is so bleak that even the science that the US so generously funds has produced nothing new in the last 20 years. These are the words taken directly from a book from my dear friend Tom Insel, who is a biological psychiatrist who led the National Institute for Mental Health, which is the world's largest mental health research funding body. And I think the words speak for themselves. So it turns out that the US spends more on psychiatrists. It spends more on mental health care. It spends more on mental health research than any nation in the world. In fact, probably all developing nations put together in one basket is less than the US. And every single metric to do with mental health in the population has worsened over the same period. So the real question is that why is it that countries around the world, including the wealthiest countries, have failed to address the burden of mental health problems in their communities, in their populations, in an equitable way? Mind you, this is only true of mental health. This is not true of cancer. This is not true of cardiovascular disease. This is not true of infectious disease. It is only the case for mental health. And I think we do need to sit and ask ourselves the question, what is it about the biomedical paradigm that has succeeded so well for many other health groups, but not for mental health? This is an issue that a group of us were invited by Richard Morton, the editor of The Lancet, to examine what might be the reasons for failure globally in terms of mental health. We put together this article as a health policy article in The Lancet in 2023, and I'm not going to go into the details of what we found because there are many things in that piece that really speak to why we have failed globally on the mental health crisis, but really reflect on the cause. What is the singular cause that we identify? And that is, quite simply, that in the mental health field, we have blindly adopted a very narrow And lastly, our focus as psychiatrists tends to be on the symptom checklists that we are so concerned about in the diagnostic systems. This is not what most people with mental health problems are concerned about. They're mostly concerned about their social well-being, their social or spiritual health. And so there is a complete mismatch between what the biomedical system is targeting and what the person with mental health problems is actually wanting. So I want to now turn to a very different story, and that is, how has South Asia innovated a very different, not a top-down biomedical, but a bottom-up, grassroots-led approach towards addressing health problems in this region? And what can we in the mental health field learn from the successes of that grassroots approach? Back in the early 1990s, when I was planning my return to India, I was in Britain completing my psychiatry training, and then I was in Zimbabwe, where I worked for 2 years doing a doctorate on mental health problems in primary care. I was introduced to this book that was published actually around in the 70s, maybe the 80s, I can't remember the exact date. It was produced by the Foundation for Research in Community Health, which at the time was one of the leading research centers. It was an NGO based in London. And the book was edited, amongst others, by one of India's great community health practitioners, Professor Anthem, who interestingly did not go to the community medicine program. He was actually a plastic surgeon. And I was a little baffled, what is a plastic surgeon writing about people's health and people's hands? It seems like such an improbable combination, especially when you think of what plastic surgeons do today. But it turns out that, of course, back then, plastic surgery was not about making people more beautiful. It was about actually helping people with leprosy who had terrible deformities, actually address those deformities and be re-included in their villages and in their communities. And he used to work with these, in those days, only some of us will remember when leprosy was still a horrendous, stigmatizing condition. People with leprosy were sent outside their village. They would actually live in these separate settlements that were outside the main village. And so Professor Andhya began to work with not just the persons with leprosy by surgically treating their deformities, but also with the communities themselves to educate them that how the new antimicrobials were in fact making leprosy a non-contagious condition, etc., etc. You know the story. It's one of the great success stories, of course, of medicine. In the book, I read a number, it was an edited volume, of innovations of grassroots action on community health in India. And one particular story caught my eye and has remained part of my own story for the last 30 years. And that story is best exemplified, by this particular woman. This is a lady called Anjana, and she lives and works in one of the villages in the district of Gadchiroli, which is in the center of India. So one of those stories was about this young doctor couple, Rani and Abhay Bam, who had gone to the United States after clearing medical school in India. Back then, there were no masters in public health degrees in India. So they had gone to Johns Hopkins, and unlike most of their peers who would have gone to the US and done, cardiovascular surgery or something and stayed there, they actually went to do public health, which back in the 70s or 80s was, what is public health? They did that, and they returned to India, and they set up an NGO in Gadchiroli called Search, and where they decided to devote their life to helping the tribal people who dominated in that area address their health needs. Very quickly, they discovered that the single most important health need was newborn mortality. The newborn mortality rates were astronomical. And the reason, of course, newborns were dying as they studied newborn mortality was primarily due to preventable causes of death, especially pneumonia and various forms of sepsis. A lot of that was related to home-based delivery. Now, no pediatrician. They try to get some pediatricians to come to Gadchiroli. I know Rani very well. I've been there almost like a pilgrimage for me to go there. They try to get pediatricians to come, and nobody's going to go. This is back in the 70s and 80s. Nobody was going to go to this remote part of India after becoming a pediatrician. So what could they do? They were watching babies die, and they decided that they would, in fact, work with local women in those villages, and with them design an intervention that would actually give them the skills to detect newborn pneumonia and sepsis using whatever simple technologies, I use the word technology here, deliberately. Whatever simple technologies, like what? Like a metronome. What do you use a metronome for? To count respiratory rates. Such simple homegrown ideas. They use these. They also thought of ways in which they could train these lay women in the community, like Anjana, to actually deliver gentamicin and other antibiotics for those babies who they found potentially had pneumonia. When they started doing this work, there were howls of protest from pediatricians and neonatologists in places like Mumbai. It said that the Bams were really doing witchcraft kind of medicine. They had to be completely stopped. Clearly, it was obvious that there was a lot of opposition from the medical sector. When asked including the World Health Organization, completely rejected this approach. Instead, the approach that they were being recommended was that of building NICUs all over these rural areas. Neonatal intensive care units back in the 70s and 80s. You can understand how absurd this was. So what Rani and Abhay did was they applied science. They agreed. It was important really to address this concern that people had that by giving women like Anjana all of these techniques and tools, maybe they were harming these newborn babies. Not doing good, on the opposite. They were harming them. So to their credit, in this incredibly remote part of the country, with no backing from any medical school, not a single rupee from the government or from any international agency, they conducted a cluster randomized controlled trial. And this paper that was published in the Lancet, at that time probably the only paper ever that came from a rural community to be published in the Lancet, has now been ranked as one of the 10 most influential papers in all of medicine history. They were able to demonstrate that in a cluster randomized controlled trial, the newborn mortality plummeted by more than 40% in the villages in which women like Anjana were working. In fact, maternal mortality also fell in those villages because, of course, those frontline workers were also motivating women to go to the Search Hospital to have their babies in institutions rather than at home. What a remarkable experiment this is, and shows you the power of grassroots-led action, marrying high-quality science, high quality that it also got published in the world's best medical journal. Now, of course, you can argue that a single trial does not change policy and practice, and indeed, when this paper was published, it shook up pediatric and maternal specialty environments. But people refused to accept it, including ICMR. But ICMR, with all credit to the leadership of ICMR decided that, quite rightly, that they needed to fund replications. And they did fund replications. Not just in India, but other agencies also funded replications in countries like Kenya and Bangladesh. I'll come to where we are today. This original trial, friends, was the origin of what we now call the Asha. If you have to track the history of the Asha, you will see that the origin story comes from this kind of innovation. They were not the only people, there were many others, the Aravis, the Chancellor, and so on. But this is the kind of grassroots innovation that led to the emergence of the Asha. And indeed, today, not only does the Indian government embrace this idea in the National Health Mission, more than 1 million Ashas and many other community health workers being rolled out, but also the World Health Organization has changed its policies around reducing newborn and maternal mortality, so that in most parts of sub-Saharan Africa today, you will also see a model that has emerged from India, has transformed maternal and newborn health around the world. So I saw this incredible story. It was deeply inspired, as a psychiatrist, a young psychiatrist returning to India and seeing the fact that almost nobody back then received any form of care. And there was not just a supply side barrier back then. We'd ignored the demand side barrier. Nobody wanted to go see psychiatrists because of the stigma that was attached to mental health. And so it was clear to me that we needed to look at grassroots solutions. I was deeply inspired by the work that Rani and Abhay were doing. I went and talked to them. I spent time in search. And I decided then that let me apply the same grassroots methods to the design of mental health interventions with the explicit goal that those interventions should be delivered by people like Anjana in community settings. I'm going to cut straight then to one example of such an intervention. And that is a brief intervention built around science of what's called behavioral activation that we designed for delivery in primary healthcare settings for people with severe depression. Importantly, just like the home-based newborn care model, it could be delivered by anyone. It did not require you to have a mental health professional background to deliver it. This program was funded by the Wellcome Trust. I was living in Goa, and I have been, that's where my primary home is since 1995. And I have founded an NGO called Sandat, which actually led this whole program in partnership with the Director of Health Services of the government of Goa. And the whole program was funded by the Wellcome Trust. At that time, I also had an affiliation with the London School of IT and Tropical Health. Before I show you the results, I wanted to just show you a brief video that illustrates the simplicity of the approach that this intervention actually embraced.
Pwede makakontra sa doon na sila stop yung buka. Ang tiyok ko rin lahat isa. Dili dili घरातले कसले काम जायना मेजॉन ना दिस भुरग्यांक सुद्दां आमी हें कित्याक घरातले करना जाय म्हाका खूब त्रास जाता घरा तेजी बायलो शिकयता आनी म्हाका खूब टेन्शन जाता तब्येत आनी हांव बरें नासता हांव जेवपाची बी याद ना आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांव केन्नाच सारकें वाडयनाशिल्लें कांय करिनाशिल्लें एक कितें करप आनी कितें घातलें आनी घालप आनी टायमूच म्हाका अशें बसोनूच हांवें काडून म्हाका खूब टेन्शन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do. For example, there may be social withdrawal, they may not be able to keep up with their work demands, they may stop doing pleasurable activities like watching TV, reading, etc. The less they do, the worse they're likely to feel. So the Healthy Activity Program is delivered over about 6 to 8 sessions. So the main focus of the initial sessions is to get patients to become activated, to start doing things that we know will help them feel better.
कितें काम कर म्हणजे मागीर ताणें रोंपो लायलो मातशें अशें भोंवोंक वचोंक लागलें आतां काटयां हाडूंक लागलें शेतान मातशें वचोंक लागलें आनी कितें भाजी पालो घरा कडेन रोवंक लागलें आनी तितून मात मागीर म्हाका म्हयन्यान करून म्हाका एक 9 म्हयन्यांनी सारकें पूर्ण तकली म्हाजी शांत बरी जाली. पयलीं तेणी 5 मिनटां पळय घरा वचून काम करी मागीर तेणी म्हाका 10 मिनटां दिलीं मागीर 15 मिनटां दिलीं मागीर म्हाका तें काम बरें जाताशें दिसलें हांवें 5 मिनटां 2 मिनटां वाडोवन जाता मागीर म्हाजी भुरगीं येतालीं मदत करून आनी इतल्यान म्हाजें आतां गोळकार हें उपास आनी म्हाजें कामूच चालू बरीं जाता आनी म्हाका आतां वखद सुद्दां नाका बरी जाल्या तितूंतल्यान आनी बरी आसा सामकी आनी आतां म्हाका खूब बरें दिसता तकली जास्त दिता केन्ना अशें चुकोवन दिता बेगीन उठपाचें भुरग्यांक शाळेक धाडपाचें जाता त्रास जाता तकली बी दुकान आदल्या सारकी.
So let me show you now the results of the trial. In the original trial, we recruited nearly 500 individuals from 10 primary health centers. They had severe depression, not mild to moderate, but only the severe form. And we deliberately chosen that group because this is, of course, the most, the most unwell. Now, what you can see here at baseline, everybody was depressed. 3 months, that is about a few weeks after the last session of treatment, those who were in the treatment arm, 2/3 have recovered or remitted. At 12-month follow-up, similarly, that 2/3 did well. And 5 years later, an independent team led by Professor Abhijit Banerjee, who many of you will know is a Nobel Prize-winning economist, who was interested to investigate the economic benefits of treating depression. Their team followed up these trial cohorts 5 years later and continued to show that 2/3 remained well. Of course, this also means 1/3 didn't, and I'll come back to the point. But it is important to point out that 2/3 of people with the most severe form of depression not only responded to just about 2.5 hours of talk time with a layperson, but they stayed well for 5 whole years after. Actually, Samvat as a pioneering organization has been working, adopting this model, which we call Sundar, and I'll just tell you about it in a moment, what Sundar stands for. And here you can see the range of different randomized control trials that Samvat has been leading, covering the whole range of mental health issues from prevention and promotion, such as, for example, working in school environments. Bihar, the largest cluster randomized control trial ever conducted, actually in schools in India, demonstrating how transforming the social environment of schools can actually lead to dramatic improvements in mental health. All the way from prevention and promotion through to the care of people living with serious enduring conditions like autism and schizophrenia, the full gamut. And all of that based on some foundational principles of leveraging the resources that communities have rather than trying to wait and asking for resources that are currently unavailable or unaffordable. Importantly, you'll also have noticed that all of those papers that I showed have been published in journals like The Lancet and JAMA, two of the top medical journals in the world. This is the kind of breakdown of ingredients. I mean, I created this acronym. Of course, it doesn't fit so well typically, but Sundar is a lovely word. It means, of course, pretty or beautiful in Hindi. What are the key ingredients of these interventions? And these are primarily really derived from the original innovative work that was done by grassroots pioneers like the Bums. Simplify the language, strip away the jargon that psychiatry and medicine has wrapped itself in, almost as a way to exclude everyone else from that field. Unpack the interventions into smaller pieces. Psychotherapy has become so ridiculously complicated that it requires years for anyone to learn how to practice. So we've shown repeatedly, time and time again, that identifying the active ingredients of these complex behavioral interventions allow those treatments to then be delivered by whichever human resources are available, and allows the specialists, people like myself, to actually perform different roles, work at the top of our license, as it were, to train, to supervise, and provide referral pathways. Remember the 1/3 who did not respond. It is that 1/3 that needs to actually be seen by a psychiatrist or a psychologist. This is the philosophy, which has gone into a book. I actually wrote the first edition of this book back in 2003, before the first trial actually existed. I was able now, on the back of a very large body of evidence that is transforming our way of thinking about mental health care in community settings, to write the second edition of the book that was based on much of the science that has emerged from around the world now, that has totally transformed the way that we think about how grassroots engagement can change the way our mental health care systems respond. And by the way, I've been speaking to some of you. I know that Kerala is a place where one of the major priorities is elderly care. I can assure you that if we adopt a hospital-centric, specialist-led biomedical approach to elderly care, we will fail just the same way that we have failed with elderly care in the United States. Not only has elderly care in the United States become unaffordable, it's bankrupting the healthcare system, and the quality of care that most elderly people are receiving is extremely variable. It's really important for us in India to not copy that system, because it is a failed system. Because elderly people also have a complex array of conditions that do not fit neatly into a single diagnosis biomedical. This kind of approach, of course, has a long history now, and my dear friend, my late colleague, Professor Paul Farmer, wrote this extremely important piece demonstrating how frontline workers, community health workers, use this term accompagnateurs, which is a French word that he actually derived from his work in Haiti with people with TB and HIV. And I'll just quote Paul, what accompaniment means. It means to accompany someone is to go somewhere with him or her, to break bread together, and to be present on a journey with no beginning and end. And I think this is a very powerful evocation of what ashras do. It's a very powerful evocation of what community health workers are supposed to do, to accompany individuals, their households, and their communities on a journey, rather than what the medical system does, which is to treat episodes of sickness. Friends, I want to end by just saying a few words of how this innovative science is transforming global health. This science is actually probably the most exciting science that has emerged from the mental health field in the last 20 years. To the extent that it's now being embraced by a range of global agencies. And on this slide, you can see the covers of reports from the World Bank and the World Health Organization, which now completely embrace this implementation science and call for the scaling up of these approaches in countries around the world. And this is not just in developing countries, if I use that old-fashioned term, or low and middle-income countries, but in fact also in the wealthiest countries. This is a document published by the RAND Corporation as part of a major initiative in New York City, which is seeking to actually transform mental health care in the world's best resource city. You will see that they adopt exactly the same language of grassroots action. In fact, the Samnath work is now also transforming global health. Here are 5 examples of science innovations that have come from Samnath. They span a range of issues. For example, the DEEP tool is a tool that has been designed to be used on a smartphone by frontline workers and ultimately parents to assess cognitive development in preschool children, because there is currently no way of assessing brain development in children until they start failing in school, at which time it's too late often to do anything. So this tool was designed to empower frontline workers and parents to actually get inside the brains of children in much the same way that a weighing scale allows us to actually measure the weight of a child. This tool has now been not only validated, but is now being implemented in parts of Africa and South America. Similarly, there are many other interventions that have now been exported, as it were. Again, I think an example of how innovations in India are so attractive that they're being embraced by countries with the most sophisticated technologies. 2 examples of the Healthy Activity Program, which I showed you a moment ago. In the United States right now, this manualized treatment has been adapted to delivery in the US. And at the moment, there is a large scale-up of this treatment happening in the state of Texas, in partnership with multiple different hospitals as well as community-based agencies, including, I met one of you over the pre-break who said that they were a priest. One of the most exciting sectors that we're working with in the US is in fact with churches. Texas is a very deeply religious part of the US, and we now have a very exciting partnership with 32 churches, mostly working with Hispanic or immigrants from Central America who speak Spanish. We're using the power of faith to actually motivate members of the congregation to learn behavioral activation, the Healthy Activity Program, and to deliver it to people in their communities with supervision and support from the healthcare system. And this idea is not only a grassroots idea, but it's also now attracting significant amounts of funding interest from science agencies like the NIH. And a second example, again, a large research study that demonstrates the impact that the activity programs globally is the Summit trial. This is one of the largest trials for perinatal depression conducted in the world. More than 1,000 mothers with depression identified from 3 major hospital systems in Toronto, Chicago, Chapel Hill. The treatment, the Healthy Activity Program, taken from India, adapted for mothers in North America, paper just published in Nature Medicine. You can see the title, Dasha. That's actually the strategy of taking these interventions and having them delivered. My point is that we are the laboratory of some of the most creative innovations in public health and clinical care. That is not coming from the private sector, it's not coming at the laboratory science, but it is coming. What this innovation is showing us is ways of redefining mental health care, and I would argue this is also true of NCD care, elderly care, palliative care. Of course, Kerala is one of the great examples of innovations in palliative. First of all, by redefining what is moving away from this very narrow idea that it's a prescription Who is going to, where is this going to be provided? Moving away from the idea that this has to be provided in a clinic or a hospital. Who is going to be the provider? Moving away from the idea that it can only be a psychiatrist or a psychologist or a social worker. And the how. Typically, the how is illustrated in this slide here, which is that you build a healthcare system which puts at the center of the system the person with the mental health condition and their family. And they scaffold it around that by frontline workers. Frontline workers is a generic term. It can be anyone. In the United States, for example, our frontline workers are just members of faith congregations. Frontline workers can be nurses, it can be social workers, it can be community health. A lot of our work in India is in fact with community health officers, ASHAs, working in the primary healthcare system of the government. But the key here is that you have a scaffolding of the person in the middle, and then you have a collaborative approach with the primary healthcare system for those individuals who need primary care doctor inputs, people who do need, for example, antidepressant medication. And then for more serious mental illness, you have a liaison with the more specialized psychiatric facilities in the district hospital. But the heart really here is the community. Without that scaffolding of the community's support, we will not be able to shift the needle of the burden of mental health problems in our country. So my last couple of slides, just to round up, friends, what I hope I can leave you with are some key messages on reimagining care. The first important message is that we need to move away from a narrow diagnosis-based focus that has dominated the mental health field. Diagnosis is important, but it is insufficient to actually address mental health problems. What we need to be thinking about is how do we address the person's felt needs. And most commonly, those needs typically involve their lived environment, social needs. We need to organize care, moving away from a one-size-fits-all model that either you receive psychiatric care or not, to recognize that the right approach for all from diabetes to depression is a step care model. Everyone should receive a low-intensity, community-based psychosocial intervention, which acts as a filter to identify those who need more specialized medical interventions, pharmacological interventions, potentially in rare instances. In order to do this, we need to empower our communities with the knowledge, with skills, with resources, and importantly also with referral pathways that are well institutionalized so that there can be a seamless flow for people with chronic conditions to move up or down. Remember, with mental health conditions, those who need admission, when they are discharged, they need continuing care as well. So therefore, these referral pathways have to operate in both directions. And lastly, we need to ensure accountability and equity. This is extremely important because as you've seen at the beginning of my presentation, most health problems, including mental health problems, are inequitably distributed in the population. And this means that the goal of our healthcare system shouldn't just be improving the national average. That's important, but it is insufficient, I believe. What we also should be focusing on is to reduce the inequalities that actually are so common in India across all health problems. This is also true of mental health problems in particular. My last slide, and this is, I know Dr. Shah, did tell me that this is, of course, a UG research week. So I wanted to maybe just end by sharing a few lessons that I take away from my 30 years of working in community health in India. What might be the research lessons or paradigms? Many of us, when we're doing research training, we think of this is largely as a technical, a set of technical skills. Therefore, this is extremely important. We cannot do research without those technical skills, sample size calculation, and so on and so forth. Many of you will be familiar with that through the course of your life. But I think there are some more profound human skills, which I take away from my own experience that I think it's important for us to focus on the problems that our communities experience. This is one lesson I learned from the Bund in my time in search, is how important it was for them not to just come up with their own research priorities, sitting in their office, but actually to engage with the communities they serve, understand better what they were concerned about, and to then frame those concerns in scientific terms to evolve research questions that they then found experiments. I've already mentioned equity, but in addition, I'd like to also mention scalability. We in the mental health field have been singularly the worst examples of thinking about scalability in our research and science, particularly when it comes to interventions. The classic problem in the mental health field, and this is also true of other chronic diseases, is that we design interventions for hospitals, and then we try to figure out how to deliver them in real-world community settings. The design process has to be exactly wrong. Start with asking the question, what can be designed in communities, in the hands of frontline workers, rather than the office, which has dominated. Psychotherapy is a very good example of that. They were designed, delivered in university hospital settings, to people with extraordinarily complex mental health conditions by highly trained people. Then we start scratching our head and saying, well, how do we transform this innovation to real world impact? Of course, it's extremely difficult to remodel a house that is already been built, as opposed to building a house on a we must break away from disciplinary silos. My own work I've learned so much from, for example, the social sciences, particularly anthropology, which is a central social science for my work, but also economics, for example. And so it's really important to break away from the very narrow research silos that many of us have. In fact, even within the medical field, like I showed you, my inspiration for my work comes not from psychiatry. It actually comes from maternal and child. It comes from HIV/AIDS. So by actually collaborating with and learning from other disciplines, both scientific disciplines, but also within medicine, other disciplines of medical specialism, is essential to really being a successful community researcher. And lastly, partnering. As Paul Palmer said, the best, there's nothing in the world that you can do that is going to be transformative that doesn't involve partnership. And partnership means stepping out of institutions, which I believe in India has been a huge problem. That has changed now. Many institutions rarely found themselves partnering with NGOs, for example. And I believe that that relationship is central, because NGOs are, civil society is, often much more deeply embedded in communities than medical students are. And so I would urge those of you, and many of you are in leadership roles in medical schools, nursing colleges, and so on in this room, is look at civil society as a partner. A partner that brings a lot of value to your work, as opposed to someone who is just often, hierarchically less powerful. In fact, the lived experience of the communities is one of the most important experiences in my work, especially the lived experience of people who I have spent decades listening to, learning from, and embracing what they've done me into thinking about what kind of research do they really want to see. So with that, thank you very much, and thank you for your patience, and once again, thank you, Shaji, and thank you to the leaders.
Thank you. Yes, this is an oration. Yes, we usually won't allow questions, but Professor Pathak, Vikram Patel, and Professor Bharadwaj, both of them will be available in the afternoon also here. The audience are free to interact with them. So a big thank you from the side of Kerala University of Sciences.
So much, sir. We now request Professor Dr. C.P. Vijayan to hand over the memento to Dr. Vikram Patel, sir, as token of gratitude. Thank you all. We now move on to the next segment. Next is the keynote address. We request the chairpersons of the session, Professor B. Ramankutty, Research Director of Amala Cancer Research Center, Amala Institute of Medical Sciences, Thrissur, and Professor Dr. Thomas Matthew, Professor, School of Public Health, Thiruvananthapuram, to take their seats on the stage. I request Professor Pankaj Bharadwaj to come out to the stage.
Morning. I'm very happy to chair this session with Thomas Matthew in the session where Dr. Pankaj Bharadwaj will be giving the keynote address. I've been asked to introduce me, and Dr. Saji has given me a long list of his accomplishments, but I don't think I will go through all of them. I'll just mention 2 or 3 things which are relevant to this topic of research. One is that he has more than 250 peer-reviewed publications. He has an H-index of over 50, 55 or something. And he's a member of the fellow of the National Academy of Medical Sciences. So, to put it briefly, he is one of the rising stars, or maybe already recent stars in the horizon of medical research in India. And his topic is very relevant. It is undergraduate medical research. Unfortunately, India has produced a lot of very good doctors, but we don't have many good role models for researchers. In fact, that was the situation when I was a medical student in the 70s, and like Vikram suggested. Incidentally, it was very good that all of these young people could listen to Dr. Vikram. He's again a superstar of research in the international arena. So, like he mentioned, you don't have many role models. I didn't have any role models. I remember hardly anyone, any professor of mine who published anything at all, to be very frank. So those were the days. Now, I'm not forgetting that we have produced in Kerala outstanding people in international research. Just to mention a few come to my head, Professor Srikumar Nair, who is heading the diabetes research in Mayo. For one thing, then Vinod Karia, who is geneticist, top level in India. Many others. I mean, these are just 2 names which occurred to me. But unfortunately, when we were students, we had no role models, and I'm ashamed to say that in those days, I had never heard the name of Dr. Shambhunath Dey. I don't know how many of people among you have heard Shambhunath Dey. He came very near the Nobel Prize. You look up, Google him, you will find out that he was an outstanding scientist who worked in Calcutta. And also, I had not heard about, I had just heard about Dilip Mahalanobis, but I didn't know much about him. And Dilip Mahalanobis is another great name in Indian medical research because he contributed to the oral rehydration therapy, which is again another great innovation which came from South Asian part of the world. One of the contributions South Asia made to international research. And in fact, people have mentioned that there's the most important research which has saved the most number of lives in the world is oral rehydration therapy. When I was being trained as a pediatrician, we used to put needles into all children with diarrhea and, kind of bring in a lot of infection to them and lost a lot of lives. But a simple thing of oral dehydration saved millions of lives in India and many other parts of the world. So these are things that we should be sensitizing the students to. I won't stand between you and the lecture. I will hand over to Dr. Thomas Matthew. And I'm very happy to chair this session with Bharadwaj, who I have known for a long time, since so many years ago when I visited his center in all in flames in Jodhpur.
Thank you, Raman Professor, for setting the background and without losing any time, I think I will welcome Dr. Pankaj Bharadwaj. We'll have our comments after this session.
Okay, so thank you so much, sir. Thank you very much, Chairs, for this introduction. So for the next, I think, 30 odd minutes, or 20, 25, 30 odd minutes, what I will do is I'll take you to a kind of experience which AIMS Jodhpur is having and some of the other institutes. But before that, I think it's my duty to express my sincere gratitude to Professor Shaji for inviting us to this place, to Vice Chancellor Sir and his entire team for giving us this opportunity to share these thoughts. Now, after the presentation of Dr. Patel, things are a bit difficult for me, at the same time a bit easier for me also. Now, what we have heard from Dr. Patel was totally kind of a research at a level which has a global impact. An impact where the policy is being framed and changed. And the topic which is now being entrusted on me to speak for the next 20-30 minutes would be to engage these young researchers, as we say, as I think in the morning Vice Chancellor was saying, catch them young. So, a bit difficult for me to have a transition from his presentation to where now these young chaps are to be engaged. But at the same time, I thank him for making my task a bit easy also, because when he said that when it is research in medical, nursing, dental, physiotherapy schools, it's not just the laboratories, it's actually that where the community is engaged, where the actual effect of treatment, diagnosis, and management is there. So I bring greetings from these two places. In my introduction, as you all know that I am coming from Jodhpur. It's the central, it's on the western part of the country. And there are two institutes which are being shown, and that I've shown purposely. Because one is my own institution, AIMS Jodhpur, where I'm currently working. But I'll be shifting my base from here to this place, which is again an institute of ICMR, which is National Institute of Implementation Research. And within 6 days, I'll be shifting my base of work from AIMS to this place as a director of this institute to work on the implementation research, where I'll be sharing some of the thoughts with you. But these two things are also important, these two photographs, because today Research Day is actually a kind of a joining between a medical school and what ICMR earlier used to do, a kind of rails. I was discussing with Dr. Patel in the morning, that earlier medical schools and ICMR, they were not joined anywhere. They were actually working parallelly. They were not talking to each other, but now the days are changed. And now ICMR, which is Indian Council of Medical Research, has some say in the medical schools, and medical school professors have some say in the ICMR. But let's start with the first slide. And I'll take you to this slide, that do undergraduate students need to do research? Now, this is the biggest question which we should have before we go to the other slides. And it says, when we say why undergraduate research matters, there are three things I think Dr. Patel also mentions. That there is a need, there is a demand, and there is a supply. We all know that these entire mechanism is built on these three things. Is there a need? And if there is a need, if somebody is demanding about that need, and if there is a demand, what are actually being supply mechanisms? Are there supply goods? So I'll come to the first part first. Is there a need to do or to engage these medical undergraduates in research? Because if you remember, 30 years back when I was a medical graduate, that time, the only purpose of medical schools was to train us in skills where we come out of the medical school as clinicians. We do our practice either in public sector or private sector. That is all what is required from us as medical undergraduates, not as a researcher anymore. And when we used to talk to us professors that I'm interested in research, they used to say, if you want to do research, I think medical school is not the right place for you. You should have joined something else, because medical schools for undergraduates are there to learn clinical skills, to learn how to manage cases, to learn diagnosis, to learn management, and that is all what is being said. But now the scenario is completely changing. And when I say there is a need, yes, there is a need, which is being mandated right from the side of students as well as from the side of the National Medical Commission. We all know, as a university sitting over here where there are a lot of medical schools, nursing and dental schools, CBME says that now it is the time to have active engagement of students in learning process. They should not be the passive listeners. They should not be the kind of a recipient where they are passively getting knowledge. They should have some critical thinking and they should have some scientific inquiry. And if you go on that side, it is very well written that yes, we all are knowing about that initially there were only the cognitive domain and the psychomotor domain, which these medical schools used to talk about. But now, gone are the days, now we have been talking about affective domain. And when we say affective domain, it is on the higher rung of learning, if you remember that pyramid. And there they need to understand how to analyze the situation, how to get, open-mindedness, systematic, question-seeking. I still remember when I was a medical graduate, I was not supposed to ask a lot of questions. Our professors, they didn't like, if somebody was asking a lot of questions. They used to say, do it like this or do it like that way. If you have questions, then go to another class. I'm not interested to answer your question. Sometimes they even say, these are untoward questions. I'm not interested to answer your question. But now it's the time when they encourage innovation in problem solving skills. And I think that is the most important part when we say there is a need. And that practice and theory gap which Dr. Patel was saying, I think this is something where we say, yes, there is a need of having research in the undergraduate curriculum. Now, we were talking about, yesterday also, we were talking about evidence-based medicine. Again, the paradigm shift, the change is there. Earlier, there was a traditional way of managing a case, but now the cases have already been changed. And now it says it is on evidence-based medicine. And when we say evidence-based medicine, these are the three circles which we talk about. And they talk about that individual clinical experience, that best external evidence, and the patient values, ethics, and expectations, which is an important part. And if you go to that circle where it is best external evidence, there comes the research, where we say that our undergraduate students need to understand how to conduct a meaningful research, how to generate data. And when we say it's a meaningful data, it's a meaningful information. As we say that garbage in, garbage out, then they should know how to do clinical research right from the very beginning and then take it to their postgraduate years and then once they are faculty or consultants in the public or private sectors. The engagement in real world context. I'll share you with this example. When the COVID-19 crisis was going on and we were requesting our medical graduates to come forward for vaccination, they were not. This study which we conducted with the undergraduate students in AIIMS Jodhpur, with the Google, all those sheets, taking the view of medical schools of all the country, that why medical students are not coming up forward for taking COVID-19 vaccine. And there were a lot of questions which these medical graduates were telling, that there are news that it is being done very rapidly, the kind of protocol which is to be maintained is not maintained, it is something fishy, government is putting a lot of pressures on students. So all these inquiries need to be there. And the study was published, and this is from this, if you look at the Jyoti Jain, this is our undergraduate medical student of second, third year, which she collected data and then we found out what are the solutions and what should be done to address the vaccine hesitancy. I think many of us remember this because many of us will agree that it is not a very good program, and I'm not going to go in a debate which National Medical Commission says when it says that family adoption program is an important part, engaging students from the very beginning, from the first years or second years or third years. So we have been invited by National Medical Commission. I was invited by National Medical Commission to analyze the data from all these FAPs. Does it make sense? Because this data is being collected by medical undergraduates. As I said, that here we are engaging medical undergraduates in research. It's not entirely research. It's just a survey. But does that survey matters? Yes, there was. The undergraduates collected data, and there were a lot of information which was not sometimes available, or which is available in a different way in NFHS. I don't know how many of us who are there from community medicine have compared this data to NFHS data. So NFHS, which is a big survey by Government of India, but this is the data which is being shared by our own medical graduates through family adoption program. So what I mean to say is, yes, as Dr. Patel was saying, that when we engage these medical students with a lot of resistance or maybe some technical things, some challenges, the students got engaged from the very beginning, and now they've started working on this. Now the FAP is moving in few states in a very meaningful way. Now these are two very important facts also, because when I say is there a need, the need should not come only from the service providers, it should also come from the students. Do students need also take it as a need of a research to do or to get engaged in research? Yes. And this is something I was talking yesterday evening also, that when we are framing anything for students, please engage students as important stakeholders also. So when we were asking about do undergraduate students need to be engaged in research, is there a need? Yes, there were answers. You can see it was one of the papers which was published, and those students who wanted to go abroad, those who wanted to have good residency program here in India also, they said yes. In our CV they say that yes, the person is being engaged. In one of the pediatric residency programs in US and Europe, they say more than 70% are there who have done something during their undergraduate years. Now the second thing which I have purposely written is on the systematic reviews. You know, the purpose of engaging these medical undergraduates from the very beginning in systematic review is a very important work which earlier was never been motivated by our peers or professors when we were students. So yes, it's a need. First of all, as I said, that I need to understand first, or we need to understand first, that is there a need right from the side of those who provide this medical education and to those who actually receives this education. Now, as I said, there is a need. So no doubt about it. Students are saying there is a need. Teachers are saying there is a need. But who's actually, then what is the demand? So is there a kind of a protocol or something where all these universities are to be engaged in? Yes, National Medical Commission. We all know that after the CDME program, the research atmosphere or ecosystem has to be maintained as a mandated activity from National Medical Commission. And they say that 4-week blocks in MBBS third year, part 1 and part 2 is an important part which they need to understand. Now I'll come to that, how we have been providing it in different schools as an experience sharing. And I was very impressed to see in the morning when Vice Chancellor Sir has felicitated most of the medical schools, and they've got a lot of research output from Kerala. I was talking to my colleague when I was sharing with her that, in North India, we always look to Kerala. When somebody says that, do something good in Rajasthan or Delhi, we say, let us look for some good clinical practices or good practices what Kerala is doing. So applaud to Kerala University of Health Sciences. They have started this research aid, a very good initiative which I'm taking home, and I think in the next experience sharing which I may be doing in Lucknow or maybe in Banaras or other states, I'll be sharing the example of KUHS. Now when I'm saying demand, then again, let us engage students. Do students also demand? As I said, when we were there on the need side, we had a view of both the students as well as the teachers. But when it comes to the demand, mandated activities from the National Medical Commissions, but do students demand also that they need to be engaged in? Then there are very many challenges. And I'm not going to go in a huge challenge list which we got from the students, but one or two we have seen, and they say that because we are not going to be assessed, we all know in medical education, we know that students are 17, 18, 19 years old chap, they don't go to, kind of series where we say that do some impactful research. First of all, they are very much interested to do only that thing which is being assessed in their exams, which they are going to get some marks or credits, which is going to get them into some PG, courses. So that is something, and they say no. If suppose we do it, it's actually a kind of a waste of time, and it's of no worth participating. If we do something else, if we go for an online coaching for PG entrance test, that is going to help us out. And then they say that most of the government, it's a study from South India only, where they say that all years we have never been exposed much meaningfully. And if suppose we have been asked to engage in research activities, they're very small research activities which we do only because of a tip which our professor said as a part of an STS training program of ICMR, but no such meaningful activity, because as Dr. Patel said, if we need a kind of an impact, we need more meaningful engagement of students. And from their side, believe me, most of the students will say that it will only add to an extra burden of their clinical duties, rotation, clerkships, and internship duties, which they are not very much interested in. So with all these challenges of need, demand, and supply, let us see what is there in the current landscape, or what actually are we providing to these young, bright undergraduate students as per the national central facilities in India. So first of all, this short-term studentship program, and as I said that I'm also going to be a part of ICMR in next 6 days as director of one of the ICMR Institute. This is a very limited offer to undergraduate medical students, where we are saying that every district in this country is having a medical school. So there they only provide around 60,000 rupees, where there is some kind of, these installments which is being given to them. And these, I don't know if some of you have already participated in this, that these 60,000 rupees are not to be spent on anything. This is just an honorarium for them. If they need a kind of support on logistics, if they need some kind of, extra money for lab consumables, it cannot be spent from this. Institution has to give an undertaking that this 60,000 rupees is their pocket money. If suppose they are doing something, they need logistic support, laboratory support, clinical support, that is to be provided by the medical school. Again, a challenge, a big challenge. So if suppose we need to give anything to them, as I said, that it needs a kind of that logistics and those funds which is required. I'll share with you one of the institute where I have colleagues and I had an affiliation also, is King George's Medical University, Lucknow, where what they've said, I think it's a very small thing, but they have made some elective module on research initiative, and they have started, like this university, we call it as Kerala University of Health Sciences. We have a similar university in UP with the name of Atal Bihari Vajpayee Medical University, Lucknow, where they have started a fund by the name of Atal Innovation Fund, where what they are doing is they are actually having a kind of a corpus fund from where they are actually spending some small amount on these consumables or logistics. Because as I said, that ICMR says that from 60,000, that bucket, you are not allowed to spend even a penny. So what we actually need to have all these things together is to have a very robust ecosystem if we want to engage these medical graduates in research. And when I'm saying so is, yesterday or 2 days back, we had a discussion with Director General of ICMR, Dr. Rajiv Behel, when he said that if something works, it only works if each part of the chain is working. And when I say each part of the chain, that means it is whole ecosystem, right from students to the publication. Everything should work, then only it is going to work. And he says that if anything goes wrong, even if single thing in the chain goes wrong, the entire outcome is going to be affected. That means if you want to do something good, everybody has to be good. If something is going to be bad, even a single chain is there, if it is not doing well, that is going to disturb the entire outcome of the project. So what actually do we need? So I have put it purposely because Vice Chancellor is also sitting here, and we all, as a professor, we all, most of the time say institutional support is not there. So what kind of institutional support do we require when we think of some ecosystem of establishing research engagement of undergraduates? Number one, the capacity building. So that is something which is very important. So research methodology workshop, a meaningful research methodology. I'll share with you what we do in AIMS Jodhpur. In AIMS Jodhpur, the undergraduate students are invited many a times in a year to participate in small workshops, and these are hands-on workshops, like I've written, reference managers. So we take only one day. We teach them, we train them on how to use EndNotes, how to use Zotero. So that is something, and that is not the whole day workshop. That is only for 1 hour or 2 hours which we do, but we invite them. And this is something which is being done looking at the curriculum of MBBS, because we are not supposed to disturb that, or dental colleges or nursing or pharma colleges. So we need to have these kind of, or SRMA, systematic review, meta-analysis. It's a continuous handholding of these students. Believe me, because in AIMS Jodhpur we have only 125 intake of students every year. Everyone is not interested, but those of them who are interested, we take them on board, and there is a continuous handholding. Mentorship program. I'll show you what AIMS Jodhpur is doing. We have a regular program. So suppose some student is attached with me in first year, he or she will be attached with me till 5th year. And the outcome of the project will be assessed in the 6th year. So it's not just for the sake of publications. It's a continuous activity which they usually do during their summer breaks or winter breaks, which we give in institution. Student research cell. In institution, because we know that there are MD thesis, PhD thesis, MCH, DM, MPH, so huge work on the postgraduate. So who cares for these small chaps? We need dedicated cells. We call them as AIMS. We call them as student research ethics subcommittees. So when these, small projects are received from the students, they don't go to the entire whole big channel of ethics, IECs, because it's a huge long channel. And students get demotivated very easily. So we don't want them to get demotivated. There are small subcommittees where again there are professors. They report to the big IEC. But if they have already reviewed it, only IEC picks because student subcommittee has already seen it. Publication support, we also give publication support, and I'll come to that how do we take that publication support? Because the kitty of money in a medical school is always limited. So one cannot allow the directors of AIMS or VCs of universities to spend endlessly or infinite on the publication. So what are the criteria which we are using? I will share with the group here. Now this is something, and as I said, I'm going to put the photograph. I request Dr. Shaji to share the photograph of today's event. This is one of the events which I participated in SMIT, Chennai. The institution name is Savitha Institute in Chennai, where I've been invited in the same program as a keynote speaker. And there they have this summit by the name of STAR, S-T-A-R. I don't know if you Google it. It's one of the biggest undergraduate and postgraduate research dissemination workshop or dissemination event, which goes for 3 days to 5 days, where they felicitate these students, and there they even handhold these students to the level of ideation, to validation, to scaling up. Even they connect them to some of the funders with which they can scale up the product. I remember one of the dental undergraduate student, along with a postgraduate in dental in the Savitha Dental College, have made some dentures, and that dentures prototype was then patented by the Savitha Institute only, and then scaled up by connecting them with some of the company people. So that is being done by those people. So what actually we need to do is that we need to have some procedures or protocols which are made available to all, each and every student. So when we induct these students, like we do in AIMS, that once the students are inducted, right from the first day they've been told that there are 3 pillars or 4 pillars on which AIMS stands. And we say first is academics, which is a quality medical education, which changes you to a good clinician or public health person or surgeon. The second one is, which is very important, is research. And we say boldly that research is something where you will be engaged in and you should be engaged in from the very beginning. The third one is public health, we say it is something which is very important, and fourth is the patient care. So we all these four pillars are to be made very clear to the students from the very beginning. Leveraging technology, websites, LinkedIn. I think we need to understand. Sometimes I was also discussing it with the team yesterday when we were having dinner together, that we need to understand the way we should interact with students should be totally different. Don't give us our own examples. We are 30 years old, medical graduate. Now the science is evolving. So they need to be, they should take leverage of technology, whether it is LinkedIn or whether it is through how they can be connected with the people who are actually being engaged in the same research that should be done. Now, this is an example of what our institution is doing. You can get it from our website. So we have maintained it. This is the name of a program with AIMS is doing by the name of SIRI. We call it as SIRI, SIRI. You can see that Student Innovation Research Initiative, SIRI. So what we generally do is every time when ICMR invites STS applications, hundreds of students apply for that. But only 5 or 10 applications could go through ICMR because ICMR has to fund all the institutions. So what we do in AIMS, these 90 applications who are rejected by ICMR will be considered by SIRI. So those 10 who are already, because these students have also put their lot of efforts, brains, and their faculties are also have put a lot of time in that. So we respect that. We ask them to put that project proposal in SIRI initiative. So what we do is that it is known as summer research studentship, and there the students can work on that. But again, this again will go to the scientific board of student research as well as ethics. So we are not saying that these 90 projects who are rejected, which are rejected by ICMR, are not having a kind of a fear of not being rejected by AIMS. AIMS can also reject them. They may be not of that order that one should work on. But yes, we give them fair chance, but that let us give a second chance to these students and we again assist them. If we find them good, they work with us on that project. You can ask us, do they get that 60,000 bucks which ICMR was giving? No. They don't get 60,000 bucks from our side, but whatever support is needed, as I said, logistic supports, lab supports, the Dean of Academics, it is written here, Dean of Academics and Dean of Research. We have 3 deans in our medical school in AIMS, Dean Academics, Dean Research, and Dean Student Welfare. Then these 2 deans, they sign this, that whatever support is needed as they have qualified CE, so that will be provided. We do, second also, the first was Summer Research Scholarship, the second one which AIMS provided, Summer Research Observership in other institutions. We send them to different institutions. I'll share with you what exactly we do. Like for example, one of our students was very bright and he was very much interested to understand how the AI chatbots work for patient care, some remote sensing mechanism. He was working in his short posting in anesthesia department, and he was informed by the anesthesiologist that the remote patient sensing is, or remote patient monitoring is very important, and because in those areas where anesthesiologists are not there, critical care people are not there, once the person is discharged, we need to understand how he or she is actually improving upon or not. So then we sent him to IIT, IIT Mumbai, we sent them to IIT, even Jodhpur. So wherever they make connection, either with the connection of faculty or they can write to these mentors and we send them. But you can ask us that how do you manage? Because there is a system in MCI or NMC. They need to, clear all those hours of teaching in the curriculum. It is only allowed during their summer vacations. It is only allowed during their winter vacation. So when there are vacation time, we allow them to go over there. And we also extend some support. You can see on the 5th point, if suppose it's a good program and the institute considers it to be a good program for that learning, we even extend the traveling support to these students to a level of 2nd sleeper ACTK. Now this is the third and a very important program, and I'll share with you the experience which we are having currently with us. This is known as Joint Group Student Research Initiatives. As Dr. Patel is sitting with us in Harvard and John Hopkins, they have a concept again, I don't know whether currently they are having or not, we call them as capstone projects. So when single student is not ready or not interested to take all the work, we invite them in groups. If suppose there are 5 or 7 odd students, we ask them to come in groups and bring their ideas, and we will mentor that. Because if you remember, STS says one student, one guide. It is very difficult because everyone is not interested, neither students nor guides. So what we generally do is we ask them to come in groups. So this is a joint group student research initiative where 3 or 4 students can come to us. Even they can ask 3 or 4 of us and the faculty also, that is also allowed. The research the research protocol is again vet by the dean academics as well as dean research. The only change in research in undergraduate is whatever application is received, it is to be jointly reviewed by dean academics and dean research. But for faculty or postgraduates, only dean research is the authority. But for students, because it has something to do with their education also, so joint signatures of dean academics and dean research is also needed. Now, this is one project which goes till 5 years or 3 years, whatever is the duration. And in each summer vacations, like for example, that student, if she's in the first year or the second year or third year, she can come to me with the project progression in all these summer vacations. When she was in her first year, second year, third year, and I need to mentor it. And guide has to give this undertaking that they cannot leave these students in between. Otherwise, they have to get a kind of a letter of warning from the dean research or dean academics. Even they can issue that letter to the faculty. Okay, so now I was coming to this. As the amount of money is always finite, and people ask us, AIMS has got a lot of funding. You have no issues, but other universities do have because they have to look after so many medical schools. What should they do? Look for the opportunities. We need to find these opportunities. I remember Med Engage program when I was approached, when I was the Dean of Research at AIMS Jodhpur. Metropolis Education, they actually contacted me and said that your students would like to participate in this program. And I was surprised that these kind of programs are actually existing. There are 2 such programs, and I'm just, because this is a conflict of interest and I belong to a central institute, I should not advertise these private agencies or pharmacy company. But yes, they are there. And they actually are providing sizable or kind of a seed money to these students to do research, and a good program for 2 or 3 years. Now, some of the studies, as I said, I'll be going towards the last part and some of the sharing of experiences, what are the outputs or impact. The impact may not be that meaningful, which Dr. Patel was saying, but definitely, as we say that these medical graduates, when they are starting their research endeavors, they make some changes. This is the study of Manipal Medical School, KMC Manipal, where they are actually showing this 20 years of mentoring undergraduate students. There, that Savita, which I've already talked about. This is something which my colleagues in Ahmedabad, they did, and that was something when they used this mobile technology, and they use these students. Believe me, as I was saying, that we professors need to understand that some of the students are good in some of the technology which we even sometimes cannot imagine. So they have used this AI for disease surveillance, and this program is running very nicely in Ahmedabad. This extreme heat and urban mortality Surat project is again being undertaken by the undergraduate students and being funded by IHMR University. Now I'll go to the last part and I'll quickly share with you one of the experiences which I said I'll be sharing at the end, that when we engage these undergraduate students, and they helped us out. This was in a final year students. There were 3 or 5 final year students. And then till internship, they help us out in getting this. So this was a capstone project. And this capstone project was on this. Dr. Patel was telling us about, yes, we are going to be the 12% population of this country in the next 5-10 years will be elderly. And when I say of 1.4 billion people, of 10% of 1.4 billion people, it's a huge number. So we've been invited by WHO to have a kind of a piloting of ICOPE. ICOPE model is integrated care of older people in this country. And we were asked whether this screening tool which WHO proposes can be used in this country. So we were given a very limited time to do this. So we thought of engaging medical students. So final year students who were already trained in all the departments, medical, surgery, gynecology, not pediatrics, but orthopedics, ophthalmology. So we invited them and we asked them, any one of them is interested to participate? They said yes. These were the 5 steps which they need to be doing in their community during their, time when they can spend time. They need to screen these people, they need to go to the community and to assess the intrinsic capacity of these elderly. They need to help interns as well as the postgraduates of community medicine to prepare that person-centered assessment plans, and referral pathway, which Dr. Patel was saying, was also to be taught to them. But I'll tell you how interesting the entire journey of this capstone project was. Now, this is that ICO intrinsic capacity assessment tool, which was provided to us by the WHO. And they say that we need to assess these elderly on these 5 or 6 areas, which is cognitive decline, limited mobility, malnourishment, visual impairment, hearing loss, and depressive symptoms. And we asked them, can they ask this small question in the community, that can they remember 3 words? So WHO was saying, ask some flour, dough, and rice. So when our students were engaged, so students said, sir, this kind of study cannot be done in our place in Jodhpur, or that too in the tribal areas of Jodhpur, because we need to, customize these words for our own community. And we asked WHO, can we do it? They said, yes, this is for what we are actually approached aims to do it. And the engagement of these students and interns help us in getting to these words. I'll show you later on. These are the screening tools. These are just 2 examples. It's a big study. These kind of chair rise tests, again, when students do themselves, they understand how much it is meaningful. And they feel so happy at the end when I show you the results, that they were able to screen intrinsic capacity deficits in these elderly people in Rajasthan. This was the step 2. After screen positive, these are to be connected to the PHC or the CHC, where our postgraduates of community and family medicine sits. And there they make their personalized plan. So this is that step 1, just an example, and then I'll take you to this study which we did in Jodhpur with these students and interns. That first of all, if there is a, for example, limited mobility by that chair test, if that is positive, we go for SPBB and then we do an intervention. This is just an example. And this is that short physical battery test. So all of us who work in community health or who work in screening of these elderly know that this is a very important tool by which even we can tell if an elderly has a tendency to fall. Something which is so important for us to understand, that when these elderly comes to our clinic with their son or daughter-in-law, then their son and daughter-in-law complains that my mother or my father do not care. I don't know, even they think themselves that they are so young that they walk so swiftly and then they fall down. It is so distressing to hear that they are saying these kind of words for their father and mother, and they are not understanding that this elderly person is having a tendency of fall. But when we do it systematically in front of the caregiver, he or she understands that his mother or father is having a tendency to fall. So this was something which we did with the medical graduate, and this is not developed by us. This is a WHO project. So we developed all those care pathway. Now I'll come rapidly to our study. So we were actually these 4 countries who were engaged in this. This was Andorra, Beijing, Occitania, and Rajasthan in India. And we tried to engage these medical graduate and interns. So try to understand, and I have purpose, this is there in the WHO website, you can see it. And you can see on the right, the students were very amazed and they were very, excited to share this finding with us when they did it. Because in most of the places, cognitive decline was the most important intrinsic capacity deficit which was seen. But in Rajasthan, it was not so. It was actually hearing loss. So when they themselves found it, they were so excited. And they said, sir, once we receive these, elderly, though we look for all the effects, though we look for cognitive decline, loss of mobility, visual impairment, hearing loss, malnourishment, depressive symptoms, but we will look for a kind of a hearing loss, which is an important issue in Rajasthan. Now we need to understand why it was so. It may be a methodological issue, it may be, but we found it. Yes, it was a case. And this is how the practice changes. That once they are doing a comprehensive geriatric health assessment, they were actually putting a lot of pressure on the hearing, this assessment. And they started looking for a hearing losses in these elderly, beside going for other domains. So this was something which we did. So these were a few villages which were adopted under School of Public Health as well as Community Medicine. Now this was something which was again shared by these students. Even you can look at the cognitive decline. The words which these students brought for us was, you can see there it is written, 3 words were not what WHO says. They says it was heart, vatki and mungra. And this was what we proposed to WHO. WHO says, yes, when you have evidence, we will take these 3 words for the manual if it is being developed for Rajasthan. Chair rise test. Our students told us there are no chairs in these, rural areas, sir. What can we do? They again sit with our orthopedician friends and then they said it is 17 inches, kind of a platform. Again, an innovative work. We engaged them meaningfully and they were bringing us so much of solutions. And believe us, when we faculty are working with our residents, we have got, difficult work and multiple works to do. But when we give something to these undergraduate fellows, we give them their due weightage. They are actually bringing us marvelous things and theories which we see. This was actually the kind of an intrinsic capacity assessment which we did with them and in interns. Yeah, and thanks to intern team also. So that was also a part. We did this second phase again with the interns, not with the medical graduates, because the personalized care plan need to be maintained. And we tried to find out, are we able to connect these elderlies to the hospital? And to your surprise, you can see that, first of all, that the assessment was okay. You can see on this step 2, this was done by the doctors in PHC. And this is done by medical students. On the step 1, this is by medical students. On step 2, this was by the actual medical officers. So you can see there is a difference of numbers, there is a difference of percentage also, but not that much. Actually, they were able to screen them in a perfect way. Now this is that personalized care plan which we made when we sit together with these young minds, these interns, as well as these medical officers. And now we are giving this book to all elderlies. Then we are screening them. Now it's a regular program in community and family medicine at Shurpur. So though it started as a project, but now we have imbibed it, we have engaged it, and it's a regular program where we are actually adopting villages and screening these elderlies and bringing them and connecting them for the continuum of care. This is how we are doing it. So my last slide. So learnings from this capstone project for us in AIMS Jodhpur was building all those ecosystems, as I said, and thanks to Dr. Patel again, that actually these are the laboratories where we need to engage our students. They don't need much money. That funding would not be an issue again for the directors or vice chancellors. But yes, students learned the integrated and holistic way through these kind of projects, problem solving in real world situation. They were engaged from the very beginning in getting a kind of a personalized care plan with screening at community level and proactive engagement. So that was something which was a kind of a lesson which we could take from the capstone project, which started as a research project, but now it is a kind of a good clinical practice in our department. So my last slide, so call to action again, that thought which we say that future in health science depends not just on education, but on empowering these undergraduate students to discover, question, and innovate. So I think it's the time when, as I said, the days have changed. We need to build this ecosystem to nurture this curiosity and drives that change. Thank you so much.
Discussion. It has been a motivating session, both the sessions, in fact, because everyone in the room is really motivated to go ahead. The university has done human work by motivating the faculty as well as the students. So we have to take this forward. Few questions are welcome. Over to the audience. Please.
about how institutions can student research. I think most of the time, many students are interested in doing such activities. In fact, some of our students are also doing some of this. But many a time, they are stuck at the level of documentation and publishing, so that their activities does not get converted to scholarships. So, do you have any suggestions?
Thank you so much, sir. I think that is something which is very important. I remember my public health professor, Professor Vikas Desai, she was my professor in Surat Medical College. She used to say that if anything good which is done and not published, you are actually doing a bigger crime than not doing it. So when you say so, yeah, so there are some journals which we have already identified for our students to apply there. Institutions have taken, like AIMS has taken some of the journal subscriptions where some of the discount or some of the lower ABC is being offered to these students, number one. Number two is, we at AIMS also follow one thing, that if suppose there is a good impact factor journal and they are accepting these articles, then some of the ABC is also being given from the side of institution. But that is a kind of a debate. Usually we take it as more than 3.5 impact factor or more, because that's a kind of a issue that sometimes students research don't reach up to an impact factor of 3.5. But yes, as you say, that faculty members, they need to find out a way to publish that in the journals. But yeah, a big challenge, which you said, it needs funding. Yes. I think others can contribute. So I may not have the answers to all the questions, but yes, as I come from an institution where kind of a funding mechanism is a bit different than the rest of the institutions.
I have some interest. If we had to recommend students to do research, the universities or the National Medical Council, including research type part of the curriculum, is it happening across India? I'm originally from CMC Vellore. We teach as part of the research methodology, as part of community medicine posting. They learn. And then under the students, they do some research as part of under medicine. But is there a move towards, my question is, because a lot of people from various universities is included in the curriculum.
So in electives, madam, they have included it, but that's a very limited 4 weeks, not more than that. Electives, but yes, it's not being completely counted in the curriculum. They have to do extra, so it's not in their curriculum. So they have put it in electives, but believe me, there is no mechanism which is being set by master. So it's an extra thing which they are doing. Though they said in their document, NMC has written that this is an elective thing they can take for 15 days or maybe maximum 4 weeks. But both the sides, there is an issue. Yeah. But for community medicine, yeah, they generally do it during a part of their training. But in electives only they can do it. The only thing which AIMS is because we are not reporting anything to National Medical Commission, so we are exempted from that.
Yeah, now it was initially when we proposed it was 4 weeks, now it just rolled down to, and along with that they had to do the regular postings. And so one major issue which particularly the medical institutions and healthcare institutions in Kerala have is that we don't have a vacation period. Unlike many other institutes where we have vacation even for the faculty, we don't have a vacation even for the students.
Okay, so that's a bigger challenge, I think, because at our place, vacations are not uniformly given to all the batches. Like for example, if it's the first year, they get a vacation of 1 month. But for second year, it is 15 days. For third year, it is maybe 7 days. So we have changed it this way. So when they're in their higher batches, they don't get their vacations. But in their first, second years, they do have vacations.
3 weeks in the first year, the CMC Vellore does that, 3 weeks in the first year, 2 weeks in the second year and another 2 weeks in the pre-clinical year.
CNC Vellore has got a very good.
But that's not adopted by other colleges. So that's why I wanted to know why is there a move towards that?
No,
It's been there for many, many years, but no other universities practice that.
I think CMC has been doing it for years together in other institutions. As I said, we need to first of all identify those who are self-motivating students, self-motivated students, and when we engage them with us, it's a kind of they motivate others also. As after this ICOPE study, many students have approached us to understand what other faculty members are doing. Like I work in elderly care, but some of them are working in palliative community palliative care. So they've reached there. So can we be engaged? Can we be having some kind of data which we can analyze? Even analyzing data, even doing that is a part of a research endeavor which undergraduate students. And it's a kind of a win-win situation. Dr. Cyrus.
Can I ask a question?
Oh yes, yes.
Nurse from the School of Family Health Studies of the Kerala University of Health Sciences at Calicut. So you were telling us in your motivational speech how faculty are able to mentor students right from intake until they are interns or possibly beyond that. One problem that we have in Kerala, especially in the government sector, is that a faculty has absolutely no clue whether they would be in the same position, in the same institution, say 3 years or 4 years from that point in time. So that is one problem that we have. The other thing is that although from various initiatives, especially the KUHS award for the undergraduate students, is a great motivation not only for students but for mentors as well, who have not had the opportunity to do student research when they were undergraduates. So what I feel is we need more initiatives to train our faculty in mentoring undergraduate students in research, and also, if possible, for the faculty to do their own research and also to mentor students. Whether there could be some mechanism in place, especially for those who are who have a research interest and want to go forward long term, to have some stability.
No, thank you so much. I think what you said makes sense because, as you said, that earlier, before 13 years, I have a career in AIMS in 13 years, but I was earlier in a state medical school in Gujarat. So that's always an issue of having transfers or under NMC, a lot of inspections going on, so they change you from one place to another. That's a part which I think we need to understand. But one thing which we do in AIMS also is that they have not been attached to one faculty cadet. It's a group of faculty. So it's very unlikely that 3 of them will get transferred immediately at one point of time. It's an unlikely event. So we need to be on the probability side. So usually what happens is that 3 group of students, so 4, they are allotted 3 or 4 mentors, but they are in a group. They know each other. It's something like when we raised this similar question to our director once we were sitting in a similar meeting. And then he said, would that mean that you're not going to go anywhere when you get a fellowship in US? Then we said, no, if you get a fellowship, we'll go. And then he said that everybody is movable, but then you can move, somebody will look after. So that is something which they do, that 3 or 4 faculty in that group. And as you said, it's absolutely true that we need mentoring of faculty, capacity building of these faculty members also in undergraduate students. Thank you so much, Mike.
Excuse me, sir. I had something to ask you, sir. My name is Siddharth. I am an undergraduate student.
doing these efforts. You know, sometimes what we feel in India also, I still remember when in the journal clubs, if it is a journal article which is written by an Indian author or by a US or UK author, the kind of a culture is different. If my student is going to ask some of the query to an Indian author, they're going to take a lot of time to reply to that. And to a US or UK, because the culture is different, they reply maybe next week, maybe 15 days, but they do reply. So the same thing we need to understand, that sometimes we stop putting efforts. As you said, I understand there is a challenge that you may not get a kind of, what expected answers from these institutes, engineering institutes, that may happen. But keep trying. I think there are exceptions and you get it. And number two, when you said about the institutional email, so AIMS also follow the same rule here. We don't give institutional emails to students because when something is attached to the institutional emails, it needs to go through a kind of a channel, which is a very difficult channel, and somebody has to oversee. And you know, when it's such a bulk or a volume, so so that's the policy of AIMS also, that the institutional email is only given to the faculty members and those who are working. So I think these are some of the technical challenges which students also understand sometimes. But yes, the kind of a dialogue is very important. Thank you so much.
I think today there were two beautiful sessions. The first session was beautiful because sir brought in the community engagement and how the community needs should be translated to research. Regarding this session, it was beautiful because it was meant for undergraduate students. And one thing, actually the family adoption program, there you have very effectively incorporated ICOP and gone in for a personalized care plan, which we call here as individual care plan. Anyway, it was very beautiful and systematic. A takeaway which I think everybody can emulate. And one more thing I should remember, Ramagutta sir, when you told there were no role models for you, actually for our generation and the generation we thought there was a role model. Health Action by People initially started undergraduate research way back in 1997, and that only sort of pushed research methodology as a curriculum in community medicine. Because Health Action by People all over India, Sir, Ramagutta sir, C.R. Soman sir, Vijay Kumar sir, we cannot forget. We teachers cannot forget. He only pushed undergraduate medical education research as part of curriculum. So I mean, I should say that. Thank you.
PS, PHP, still remember when I was a student, CMC Bangalore started a problem solving for better health. And, all Kerala institutes were the leads, and we had,
it started with HAP.
Yeah, and we actually used to follow it, and I was there at the time in Allahabad Medical School, and we used to hear PSPH from Kerala. Thank you so much.
Sir, I am Dr. Suma, was Professor of Medicine and currently working as ICMR Emeritus Scientist. So, okay, thank you. Thank you for the excellent presentations, especially filled with practical points, and also I think that must have inspired everyone sitting in this room. One question about the publications. As you have said, rightly said, in STS they say that one guide for one student. So this question came from some institutions here itself, that one person will be leading the project and then the other people also will be helping. So when it comes to publications, whether they could include the other students, other peers, other students also in the publication. I thought that it would be the idea to have the others also contribute.
Absolutely, ma'am. As per ICMG criteria. So we need to follow ICMG criteria only. And it's written very explicitly in the STS framework that whosoever has contributed need to be there in the authorship. The only thing is they want acknowledgement of ICMR, and that is to be there. The only thing that they stop the last check. So many students, they miss acknowledging ICMR and they stop the last check from ICMR. So I think that's the only thing. But otherwise, all of them will contribute.
So you were talking about you have selected certain journals where the students' research would be.
I can share that with Professor Shaji also. So we have one thing which we can do is when we going all these kind of experience sharing, that we have a lot of compendium with us. We can share that. I think networking help us in getting what other knows and what everybody should know. As I said, that many of us may not be there knowing about that these CSR activities are going on, and they are engaging only undergraduate students. They are giving these seed monies to only students and not even the postgraduates. So that is something I think that we can definitely, I'll be more than happy to share.
Thank you very much.
Just a journal editor, just say, journals have different priorities. So wouldn't it be nice for universities to have journals to actually have this as a priority? They get the right channel to publish it. Once the need is there, the interest actually comes further. So health sciences could be revived, and probably we can have a few of those published.
I think a very good idea, and universities should start their own journals.
Yeah, I think it is on the anvil. So, annals of health sciences.
In the August audience where there are a lot of teachers also, I would like to bring to the notice of the people that we have a system on the NMC, particularly the NMC Advanced Course Program, whereby the teachers are conducting educational projects in their campuses. And this is one way by which the students become subjects or participants in the research activity, which is done by the faculty members. We take 30 teachers every 6 months, and many of the audience sitting here are already participants of the program or ex-participants of the program. So we have a system whereby the system of educational research is being implemented to the campus to these teachers. And the students happen to be volunteers, or they are the subjects in the study. So that way also they have got some exposure to the research that's going on in the campus, rather than them getting a belief that there is no research that is happening in the campuses.
Thank you, sir. We have been carried away by the session and the thoughts, and it's time for us to call it a day. But if there are any more pressing questions, we'll take it up. It will be the last question, otherwise we'll conclude, because this has given us a unique opportunity for further thoughts. Yes, please.
As a student, I am asking that what are the benefits and improvement by doing the PG or research work after by B.Pharm degree or other degrees?
Yeah, so I think specifically because we also have, but we don't run B.Pharma courses at AIMS, but we have our partnerships with the B.Pharma schools. AIMS have a regular partnership with that. But when you do good research in B.Pharma schools, I think that has a better potential to enter into all these clinical trial units. I'll tell you one of the program which is run by the ICMR by the name of Intent. I don't know how many of you know it. It is by the name of Intent, where earlier 2 years back, ICMR was not supposed to conduct the clinical trials. But now as a mandate, any clinical trial which is coming to the institute, to our country, needs to come through ICMR. It is after COVID-19. So whether you're doing it on remdesivir, whether you're doing it on plasma trial, vaccine trials, or new repurposed drugs, that should come out through that. So B.Pharma students who have already conducted researches have got a good potential to be absorbed as the trial, CROs and other who actually helped in medical schools, because medical schools don't have capacity to do clinical trials. So I think it will, straight away improve your CVs to be absorbed and to be looked by these medical schools, because these B.Pharma schools are supporting medical schools in all the upcoming clinical trials by ICMR. So to make your CVs stronger and to be a potential candidate for recruitment, I think it makes sense.
Is any internship opportunities for research?
For research there are internship opportunities. You can apply for internship opportunities in different ICMR institutes again. AIMS do not provide it. I don't know about medical schools. But yes, ICMR and other, like for example, THSTI, which is there in Faridabad. So they provide these internship opportunities, and different these schools which are under CDSU or TCGI, they also provide some of the opportunities to pharma students to do internship. Thank you.
Currently, there is an application, call for application for Intent. Sir, there's a call for application for Intent where the date is extended also.
Oh, sorry.
Currently, with ICMR, there's a call for application for Intent, and they have extended aids also.
Yes,
I don't know, but whether the students could apply for that.
No,
So
intent that is to be applied by the institute. So there is a, I don't know whether in your KUHS who's the PI of that project. So when ICMR called for the intent, they've invited all medical schools to put a team to apply as PI. So vice chancellors or directors have to sign that. So now what we are doing is every time when there is a new drug or new modality of treatment, we invite medical schools to put expression of interest through intent centers. And I think somebody of you must be there because Kerala, I remember one of the center of intent. So then he or she has to apply, but they can take on board the other pharma schools. But the prime PI can only apply for that.
Thank you, Dr. Bharadwaj and Dr. Vikram Patel. Along with sir, I take this opportunity to thank the Honorable Vice Chancellor, esteemed Vice Chancellor Registrar, and also Dr. Shaji, who is the Dean of Research. They have really worked hard to make this day memorable and instilling us with a lot of ideas for further growth. And I also want to thank each and every one of you here who has made these sessions lively, and I hope that you will go back to your institutes or institutions and make fruitful research blossom. Thank you very much. Thank you for this opportunity.
Thank you, sir. I request Professor Ramakundi to hand over the memento to Professor Pankaj Bharadwaj as the token of appreciation. Thank you. Now the post-lunch arrangement will be explained by Dean Research.
Briefly, I think there are going to be, after lunch, there are going to be 3 groups. One group of students are going to be here, and that will be managed. We have informed faculty, and the Dean Student Affairs will supervise the program here. It will start at 2 and it will go on up to 3:30. Whereas the faculty who had mentored as well as other faculties can join the academic council hall, 6th floor. Be there. The idea is starting of a year-long engagement with stakeholders like students, faculty, and administrators and policymakers. So the speakers will also be there near the Vice Chancellor's room and outside that there is a small place where an informal discussion will happen. So thank you very much for being with us. I hope this message will be taken back to your institutions. And one thing, sir, we will be soon announcing a follow-up program for support of 2024 applicants, 185 people, even those who could not get, mainly to support them in scientific writing skills. So they have a program this year where they and their mentors, if they decide to join as a joint program, that will be online. Thank you very much. We are delighted to have many senior people here. Thank you for your time. And I think the YouTube video live streaming will stop now. And we will have in the Academic Council Hall an option for some of the faculty might decide to join also, some may not. Thank you very much.